Chapter 40, Alterations of Renal and Urinary Tract Function in Children. Development of the urinary system, just to go over some of the developmental processes. They're developed in three structures, pronephros to mesonephros, and basically these develop into the functioning kidneys. Urine formation and excretion begin by the third month of gestation. The embryonic development, you can see the urorectal fold, and then eventually they mature into a rectum and bladder and kidney. Wilms tumor development of urine system. Wilms tumor is a WT1 gene, plays an important role in the stages of kidney development and the maintenance of kidney function. The kidney reaches the size by adolescence and increases with weight about tenfold from birth. So here you have a gene that causes tumors in certain people, and actually is absolutely essential for the development of the kidney. Blood and electrolyte balance. Blood flows to the kidney in the newborn and primarily through the medullary nephrons, and because of the short loops of Henle and the medullary nephrons, the infant produces more dilute urine. Infants are high in anabolic state, and therefore their urea excretion is low. Infants' narrow chemical safety margins. They have high hydrogen ion concentrations and low osmotic pressure, and limited ability to regulate internal environment. The immature small tubule surfaces diminish with water absorption, so they're fragile. We know that. Immature tubular transport capacity is the ability to excrete potassium, reload bicarbonate, and does not become efficient until approximately the age of 2. So therefore, as we see in third world countries, that for instance cholera and other infectious diseases that lead to diarrhea in children can be quite profound and lead to their early deaths. So that's what we talked about, making normal saline replacement by using a tablespoon of salt in a quart or liter of water, and giving it to the children or adults when they have infectious diarrhea, particularly cholera. Location of body water. After birth, the proportion of total body water to body weight does not significantly change, but the location of the water does. The extracellular fluid of a newborn infant is nearly double that of an adult. Decrease in ESF occurs during periods of rapid growth, infancy, and adolescence. Total electrolyte concentration in extracellular fluid is greater in a newborn than an adult. Exchange of body water. Adults take in and excrete approximately 2,000 mLs of water, or 5% of the total body fluid, and 14% of the extracellular fluid. An infant exchanges between 600 and 700, or 290% of the total, or near 50% of the extracellular volume, making control of dehydration and overhydration more difficult. So children are more difficult to manage. Which statement is correct regarding fluid and electrolyte balance? Infants excrete approximately 2,000 mLs per water. Now it's an adult. Percentage ECF volume in a newborn infant is nearly triple that of adult. No, that's incorrect. The infant produces more dilute urine when compared to an adult. That's true. The infant's kidney is more responsive to ADH. No. Let me go back and hit escape, and this is the answer 3. So you can see that 3 is the infant produces more dilute urine, right? Okay. Congenital abnormalities. The most commonly associated with urinary tract malformation is low set of malformed ears, sensory urinary deafness, chromosome disorders, urinary associated with trisomy 13, Patu syndrome, and trisomy 18. Absent abdominal muscles, vertebral extremities abnormally, imperforate anus, renal and extrarenal tumors, ocular abnormalities, and hepatic cysts and cirrhosis. Congenital abnormalities continue. Hypostasis is ureteral meatus is located in the ventral side of the upper surface of the penis, and you have to fix that with surgery. Epistasis is males. Urethral opening is on the dorsal surface. In females, the cleft along the ventral urethral canal usually extends to the bladder neck. Twice as many boys are affected as girls, and surgery is needed to fix either one of these. So when infants are born, that's one of the things that the pediatricians look for the neonatal, nurse midwives. This is the glands of the penis, and this pointing here, and then you can see the urinary meatus is here, not open here. See, so that's hypostasis. Hypo meaning under, right? Less than under. And then, so this is the hypostasis. We just saw an epistasis would be up here. This is the urinal meatus. These are the two halves of the scrotum located right in the middle of the penile shaft. And this is the chordae of the penis. Exoptrosis of the bladder is a herniation of bladder through the abdominal wall. Occurs within a failure of the abdominal wall muscle, pelvic ring. Ideally, the bladder and pubic defects should be closed before the infant is 72 hours old. Surgical reconstruction is usually performed. Uropelvic junction obstruction, a blockage of the tapered point where the renal pelvis transitions into the ureter. And then you can have bladder nut obstruction, ureteral valves, ureteral polyps, and an absence of the urethra, which is a congenital abnormality. Prenatal bladder shunting with resection during the first days of life. So in prenatal, the bladder shunting with resection after in the first days of life. Renal aplasia, the kidney is absent. A hypoplastic kidney is a small decreased number of nephrons, and renal dysplasia is a result of abnormal differentiation of the renal tissues. Renal agenesis is the absence of one or both kidneys. Unilateral, usually the left kidney is absent, remaining the remaining kidney hypertrophies and lead to normal, healthy life. Potter syndrome is a bilateral renal agenesis, a rare disorder incompatible with extrauterine life. And Potter's association is associated with a specific group of facial abnormalities, web-set eyes, parrot beak nose, low-set ears, and receding chin. Children with unilateral renal agenesis is seen in clinic. The nurse realizes that they require dialysis. There's a hypertrophied kidney, may have facial abnormalities, may be susceptible to infections. Number 2, right, congenital abnormalities continues because it's hypertrophies to help the other kidney continue to develop. Okay, congenital abnormalities continue. Polycystic disease, PKD, autosomal dominant disease, mutation of 2 genes, PKD1, chromosome 16 and PKD2, chromosome 14. Cystic formation obstruction accompanied by destruction of renal parenchyma, intestinal fibrosis, autosomal recessive PKU, cystic changes in the kidney and liver, and genetic mutations. Glomerulonephritis in the child is an acute renal disorder with proliferation of inflammation of glomeruli, and secondary to the immune systems. Sudden onset of hematuria, red blood cell cast, and proteinuria, accompanied by renal salt and water retention, edema, hypertension, and severe cases of azotemia. Chronic glomerulonephritis is chronic, causing 15 to 29% of children renal failure. The post-streptococcal glomerulonephritis, PSGN, occurs after a throat or skin infection with certain strains of group A amyloidic fat. Antigen-antibody complexes complement are disposited in the glomeruli, and immune complexes initiate inflammation and destruction of the glomeruli. Occurs in children between 5 and 15. Obviously, this is a component of autoimmune dysfunction. Remember, we'll talk about an adult glomerulonephritis. It's really an autoimmune disorder, even though it's triggered by infection. So PSGN, clinical manifestations, hematuria, hypertension, treatment, restrict fluid, administer hypertension, diuretics. Immunoglobulin A neuropathy, the most common form of glomerulonephritis in children, the deposition of IgA and complement proteins in the mesosangumen of glomerulus. Gross hematuria concurrent with respiratory tract infection, supportive treatment, dialysis, and transplant. And this is what glomerulonephritis looks like. In A, normal glomerulus, this is normal, and then B, the acute post-infectious glomerulonephritis. You can see that the cells are all inflamed. These are normal cells, you see, all hypertrophied. And C is a post-infection irregular mesenchymal capillaries. Alterations purpura nephritis is also referred to as anaphylactoid purpura. It's an immune-mediated immunoglobulin A vasculitis. It causes inflammation, damage to glomerular blood vessels. It's pretty rare. I've never seen it. Abdominal pain, palpable purpura, arthritis. Seeing that obviously immune disorder leading to arthritis in children, like in rheumatoid arthritis. Treatment, most children recover with supportive care. Some progress to renal failure. Some people require steroids, immunosuppressive drugs, and ACE inhibitors. Hemolytic uremic syndrome, HUS, is the most common community-acquired cause of acute renal failure in children. It most occurs in those younger than 4 years old. It is associated with bacterial, viral, and endotoxin agents such as E. coli O157, and bacterial toxins of E. coli damage red cells and endothelial cells. Arterioles of the glomeruli become swollen and occluded with fibrin. So this disease, HUS, decreased glomerular filtration rates. Swollen vessels cause damage as they pass. Spleen removes the damaged red cells from the circulation, and microcirculation develops the numerous thrombi. Clinical manifestations preceded by a prodromal of gastrointestinal infection and diarrhea, sudden onset of pallor, bruising, purpura. Treatment is maintain nutrition, hydration, dilute toxins, control hypertension, hyperkalemia, and seizures. When renal failure occurs, treat with dialysis. Blood transfusions with packed red blood cells are needed to maintain and recover hemoglobin. Most children recover.